more recent publications and data about whether or not you should realign the distraction injury or not after blunt force trauma. And there were publications that were published in the late 90s and early 2000 time period that really was in favor of trying or making an attempt at urethral realignment. In fact, in a disruption injury, you were encouraged to at least try to realign the urethra prior to placing a suprapubic tube. And I think that that thought process has changed, and it's important that, and I know that we practice here with the thought process that really if alignment is possible and feasible, we may take a look, but we won't spend much time doing it. And the preferred method of urinary diversion after distraction injury is a suprapubic tube. And I agree with that. I'm very much in favor of that. So when we talk about the urethral trauma approach, I think looking at the 2020 AUA guidelines is probably the most important thing to do. So first of all, the patient that has blood at the urethral meatus after pelvic blunt force trauma should have a retrograde urethrogram. I don't think anybody disagrees with this, nor is it news or anything different than what's been done for years. Clinicians should establish prompt urinary drainage in patients with pelvic fracture associated with the urethral injury. So if you think you have an injury, you should rule it out with a rug. If there is an injury, that bladder, that urethra should be diverted or drained or addressed with a catheter. The percutaneous or open suprapubic tube placement is the preferred initial management for pelvic fracture injury cases. And pelvic fracture urethral injury, or PFUI, or even you'll see PFUDI, pelvic fracture urethral distraction injury, is a common acronym that I'll just make you guys aware of now, because it's something that you will see often in our notes, and this is exactly what we're talking about. Finally, surgeons may place SP tubes in patients undergoing open reduction internal fixation of pelvic fractures. So it's the expert opinion of our urologic association that, or even if orthopedists are doing open reduction, plate fixation of the pubis, doing work on the femur, X fixes, whatever they're doing, our literature supports placing a percutaneous suprapubic tube at the same time. Midline suprapubic tube is absolutely fine. There's some orthopedic trauma literature that suggests that a tunneled paramedian suprapubic tube will lower the infection rate of their hardware. We don't, as a urologic association, we don't necessarily feel that that's necessary. I'm sure that the debate will go on, and we've had some cases where tubes have been removed and replaced based on different thought processes, but it's important that we know exactly what the Urologic Association says as a society. And then you may perform primary realignment. This should be the highly selected patient. A urethral distraction injury in an otherwise hemodynamically stable patient with pelvic fracture associated injury, you may try, using a flexible scope to see if you can find the proximal urethral orifice and get a wire across it and a catheter in. You should not have prolonged attempts at endoscopic realignment. You should, whether they're hemodynamically stable or not, you want to minimize the disruption of the local tissue or nerves and blood vessels. You're much better off just aborting the realignment, placing a suprapubic tube, and coming back at another day to do their formal urethroplasty.
Excellent, Joe.
Yes.
Hello?
Yes. Is there a question? Okay, so the next guideline point is that clinicians should monitor patients for complications for up to at least a year following their urethral injury. And I think this is a very common practice of ours as well. If somebody has been realigned or if a catheter was able to be placed despite some degree of extravasation on the retrograde study, then leaving it in for an appropriate amount of time. It's typically for me, it would be a minimum of 4 weeks. And then doing a voiding trial after with follow-on cystoscopy. And my personal practice is, if it looked like a fairly severe injury, I prefer to do a cystoscopy within the first 2 to 3 months after the catheter's been removed, and then serially follow them with either repeat cystoscopy or Uroflow studies with post-void residuals to be sure that they are voiding well and that there's no sequela or delayed reformation of their injury in the form of a stricture. Surgeons should perform prompt surgical repair in patients with complicated penetrating trauma of the anterior urethra. I agree with this if it is sharp penetrating trauma of low energy. I think, and their follow-on statement, I think, is very important for us to remember. Primary repair should not be undertaken if the patient's unstable, the surgeon lacks the expertise, or the setting is an extensive tissue destruction or loss. And the case that I think of personally, you know, we all have these cases that stand out in our minds of injuries that were, you know, just devastating injuries. And one that I addressed was a adolescent 16-year-old kid and his buddy were playing around, and one pointed and fired a shotgun at the other one in the perineum and just blew out his bulbar urethra. And although it was a penetrating trauma, the amount of urethra that was devastated by this did not allow for an immediate reconstruction. And so that would be an example of a case where you would just pull back to a perineal urethrostomy or suprapubic tube drainage and then come back another day to reconstruct formally the urethra in a staged manner. And then finally, clinicians should establish prompt urinary drainage in patients with straddle injury to the anterior urethra. So whether or not there was a distraction, if there's obvious bruising or an injury after a straddle mechanism in the perineum, then placing a catheter and letting that heal is a recommendation of the AUA. Any questions on the guidelines at all? Okay, so now, you know, this is getting a facility to perform the ideal retrograde urethrogram is difficult in the setting of the radiologist's hands almost universally, globally. And so I think that this is one of the imaging procedures that we as urologists need to own as far as knowing how to do it correctly. There certainly is no harm in trying to teach our radiologic colleagues, but I think that it's very useful to have a good idea in your mind and know and be very, very adept at performing this study yourself. And so the positioning of the patient is critical. And when if a patient is laying supine and has an AP type of image, you get this image on image urethral picture that's really very difficult to read. And you can see the eyes here from the mask of the pubis, if you will, that shows that this patient's in an AP position.
Joe?
Yeah.
Excuse me. I'm not seeing that image that you're mentioning. Is it something I'm doing wrong? I see your PowerPoint with all the little panels on the side. I'm not sure if others are seeing the same thing.
Is somebody seeing are you guys seeing a KUV image with a,
No,
No,
the
we are not.
US, but
you're not?
No, first, the first slide.
How about that?
All the first slide I never see the other slide.
We're still
Only
seeing
the-
we're still only seeing your opening introduction,
Oh
and
my
then
God.
along your panels on the side, your
Okay.
PowerPoint.
Help me. I need help. Hang on a second. I'm getting help, guys. What did you tell me earlier?
Joe, you're the IT guy, Joe. You know everything.
I know what I'm doing. I don't want to share, dude.
Yeah.
Can you see this, guys?
Now we're seeing your new slides. Yes, now we're seeing
Oh,
the
man,
big
I
slide.
I
Yeah.
apologize. I really, and how about now? You can still see it?
Yes.
Okay.
Yes, the first. That's it.
Yuri, is it better?
Yeah.
God.
But,
All right. Well, I really
we
apologize.
enjoyed listening to you, Joe.
Yeah. Oh
Yeah.
my God. It's like you were probably thinking of, should I shove this pencil in my eye or keep listening? I'm not sure which one's more painful. So sorry, guys. Okay. So here's the shot. Hopefully now you can all see that when too often we get a rug or order a rug from the radiologist and they just give us an AP type of picture. And you can tell that the two obturator foramen are symmetrically located with the midline pubis. This is an AP shot. We get a density on density image from the urethra, and it's just very difficult to tell what's going on. This is a normal rug. Imagine if there was extravasation all around here, and we would not be able to tell anything at all of what's going on. So it's important to have the patient either obliqued. If your imaging apparatus can only take AP pictures, then you oblique the patient to 45 degrees. If you do move the patient oblique, then you want to put their bottom leg at a 90-degree angle and keep the upper leg straight, so that you can facilitate what I call the bicycle position with their pelvis obliqued at 45 degrees. Alternatively, if you do have C-arm fluoroscopy, you can keep the patient in the AP position and let the C-arm do the obliquing to get your image and rotate. But the key to this whole thing is the patient has to be obliqued so that we can see the entire urethra. So that we're not seeing this, we want to see that that they are obliqued and we get the whole picture and image. So if you're in the trauma bay and a patient's on a backboard and they're all buckled down and nobody's going to let you bicycle them or move a leg at 90 degrees, I still find that you can put a 45-degree bump under the entire backboard. And even though the patient's laying flat on the board, you can move the whole board up at 45 degrees, get access to the penis, sterilely prep it. I just use a catheter tip syringe that's well lubricated and place it directly in the urethral meatus. I don't personally find that putting a Foley catheter and filling the balloon with 3 to 5 cc's is useful. I just place the syringe itself in the meatus, inject retrograde, and then if it is plain films, I'm in the trauma bay, I have them take one shot that's just a scout film with no contrast, because sometimes there's hardware, there's shrapnel from gunshot wounds, there's things that look like contrast that you can't tell for sure if it's extravasation or not. And then you inject 40 to 60 cc's. You try to have them bear down and then relax so you can fill their prostatic urethra and bladder. And then you have them take the shot. The most important part of this whole procedure, and I tell you guys this when you're doing cystoscopy and other thing, it's your non-dominant hand that is the most important thing. And just like doing a retrograde urethrogram study, if you're right-handed like I am, the left hand has to be pulling the penis straight and keeping it straight throughout the entire injection process. That's the only way you get a complete image of the entire anterior urethra. And then if the patient's relaxed enough or not completely distracted with an injury, you can get contrast filling of the prostatic urethra and the bladder. And so this is a normal study. This is a well-done study. The patient is obliqued and you can see everything you want to see. So what other types of imaging studies do we do in addition to RUG or as an adjunct to RUG, which is retrograde urethrograms, that help us evaluate urethral strictures? Well, back in the 90s, Dr. McInich from UCSF published a lot of article or journal articles on using ultrasound in addition to retrograde urethrogram to evaluate the degree of scarring of the spongy urethra during imaging. This was a cumbersome thing to do. You had to really inject the urethra with some kind of viscous, either lidocaine or gel, to get a good image and a contrast between a coapted enclosed urethra versus a normal compliant and open urethra. And so ultrasonic imaging really hasn't caught on. You could see how if you did perform it and you did distend the urethra with a viscous substance, you can get a very good idea of the degree of scarring in the spongy urethra and your need for actually excising urethral segments in order to affect a good repair. And so you probably would have more information as to whether or not you're going to be able to augment this repair, whether you think you can do an excision with a primary anastomosis, or whether you're going to have to do some sort of combined technique with the adjunct of the ultrasonic information preoperatively. The point is, I think most of us just do retrograde urethrograms and kind of figure it out while we're in there operatively, whether or not we're going to need to do those procedures. So ultrasound exists. There's a real role. It's good for preoperative planning, but it's not often used. One thing that is very useful if you have access to the bladder is a VCUG. And I say access, meaning typically the only time I really tried it, may consider getting a VCUG, would be if I have a suprapubic tube already in place and I can fill their bladder with contrast. I think retrograde filling from the urethra all the way to the bladder and then having them pee back, that contrast doesn't make sense. I think IV contrast filling of the bladder and then having them void is not something that we really have time to do. And there's no guarantee that the contrast load to the bladder is going to be adequate enough to allow for imaging of the urethra. So really the only practical sense of doing what Frank Burke's partner of mine, who works with IDU Med, the volunteer urology group that we work with from Michigan, calls an up and downogram. And so getting a VCUG is very informative. If you just used a cystoscopy to evaluate this urethral stricture, your scope would not get beyond here, and you would be unable to evaluate the remainder of this segment. Now, if you could fill it retrograde, then doing a RUG alone in addition to the cystoscopy is probably all you would need. But it certainly does give you more clear information if you're able to get both imaging from above and below. My preferred imaging from above and below is, and this is just more on antegrade and retrograde evaluation. So my preferred way of doing a antegrade and retrograde study of the urethra to figure out the degree of distraction injury in a patient that has a prior suprapubic tube is to just to do cystoscopy and then a retrograde urethrogram while the camera is being placed in antegrade through the suprapubic tube tract down through the prostatic urethra and is at the level of the proximal injury. And I think that the antegrade and retrograde approach is very important to do, especially in distraction injuries, because you want to get a feel for just how much of an injury you have to deal with. So this is a rug that we had done in a patient. Sarushan, I saw this kid, a rug that we had done in a patient that also had contrast in his bladder at the time of his rug. I think that he was still inpatient in trauma, and so his bladder neck's not open. And this marking is from the radiologist, and he's calling it an 8-centimeter stricture. And what it is the lack of the bladder neck and prostatic urethra being open and filled with contrast. And so this is the point. These are the cases where you need to have some sort of better antegrade evaluation to figure out what's going on. If they can relax and if they can void down to a closed proximal urethra, then it's useful information. But trying to get young men to relax enough while you're injecting retrograde in their penis and filling it with contrast is a big ask. It's a hard thing to get a man to do. And so if you really want to evaluate this, I think that placing a camera in the suprapubic tube tract and then visualizing where that segment ends while you inject retrograde is much more informative information. And so this is a different and more recent distraction injury. Actually, they're both, this is in the last week, both these cases were evaluated, and we're setting them up hopefully soon for doing a membranous urethroplasty. But you can see all of this distance that you can get through that voluntarily a patient will not relax and void for you all the time is very informative in really determining the degree of distraction injury that you're going to have to address. And this is actually a pretty sizable distraction. This camera is all the way down to where you can see normal proximal urethra as we're injecting retrograde. This kid is a very young kid, and he was a motor vehicle accident, and he has been trying to pee proximally to see if he could leak. And Dr. Thomas and I did this case together, and as we're injecting contrast, you can see his bladder here. He's actually created a fistula in his proximal urethra because he could generate such force trying to pee that he's had extravasation. He had a little opening in his proximal urethra, and as we filled it with contrast, he had this extrav that was coming out. So I had to actually ask him to stop trying to void and just let his suprapubic tube catheter do the draining. He has a very completely obliterated injury in his membranous urethra, and he's got this persistent hang up that I think we're going to have to mobilize and figure out what's going on here. So this is a complex case that's important to know all the details of both antegrade and retrograde before you figure out where you're going to go with this kid. And so this is exactly why we want to kind of get the full picture of what's going on preoperatively. In terms of when we are injecting retrograde contrast, we can expect to see extravasation like this. This is a pretty classic picture, post-pubic fracture of a posterior injury with extravasation. And this is a case that if they were not hemodynamically stable, we'd go right to a urinary diversion with the suprapubic tube. If they were urinary or hemodynamically stable, you could consider a single go with a cystoscopy to see if you can realign them and get through. But you wouldn't, the point is you wouldn't want to spend a lot of time trying to realign this urethra. Just simply diverting the urine proximally is perfectly adequate. This is just a straddle injury, similar kind of outcome. and similar type of picture. You could consider trying to scope and get through this or realign if they're stable and you have the time and the facilities to do it. If that's unsuccessful, then the recommendation by the AUA, even for straddle injuries, is not to have them void through this, but to proximally divert them and come back and reevaluate the urethra at a later date when it's more stable. And then finally, there's anterior bladder neck injuries from traumatic types of blunt force trauma. You can see the wide diastasis of the pubic symphysis here. So there was a high degree of force that was generated. And these type of bladder neck injuries, although this one is very small, you could argue that you need to actually explore from above and go fix this early to prevent future problems with continence and other things like that. I'm not sure that extravasation to this small degree would convince me to go wade into a freshly injured patient's bladder neck area where there's going to be a lot of bleeding and hematoma. But these are things that you do want to look for. The more proximal bladder neck injuries are not always okay to wait on and not go and repair. Those are ones that might require some sort of immediate repair. Same thing with a bladder injury near the trigrone or ureters, or a intra-abdominal and intraperitoneal type of bladder injury that's communicating with the peritoneum. There's a lot of clinical findings that we get that suggest that there's bleeding within bucks or deep to bucks fascia. We know that bucks fascia inserts along the perineal area in a very uniform and concealed manner. And so it's a very classic butterfly type of hematoma that we get with injuries in this area. And so should we see this type of injury, that with a high degree of suspicion, there's bleeding beneath bucks. If they've got the right mechanism, then that there's some degree of a urethral injury, or at least a spongy urethral injury. So remember, early management, we drain with suprapubic tube. We consider realignment only if it's the ideal patient. Otherwise, abort the realignment and go right to the suprapubic tube, period. So in the stable stricture, how do we manage that patient? So post-traumatic, or the patient that presents to me in the office that has a urethral stricture that was diagnosed by their outside urologist or has had voiding symptoms, and we did cystoscopy and we found that they do have a urethral stricture. The question between whether we do dilation or incision of the stricture or immediately go to an open repair is something that's definitely evolved in the practice of urology, and as well as the recommendations of the American Urologic Association. And I think conservative dilation or incision of a stricture is reasonable to do at least once in a patient, but really not more than once. If a patient has had a dilation of their stricture or an incision of their stricture and has failed, then I typically would recommend that we go right to doing some sort of open repair. And what type of invasive and open repair is, I think, going to be a series of follow-on lectures, because there's just there's a lot to talk about. There's a lot of things that have evolved, including something called the non-transecting anastomotic repair for invasive approaches that I'd like to spend more time on rather than just blow through. But part of the decision-making process is the location of the stricture, the length of the stricture, and then what prior interventions have occurred. And again, the number of interventions is very important. I think it's sad when we have a patient that's presented to us and has had, dilations for years or 4 prior incisions or urethrotomies, and keep having recurrent strictures, and nobody has really considered doing an open repair. And so if we look at, published journal articles about the expectancy of effectiveness of a urethrotomy, I think you can get the feel that the recurrence rate is very predictable and it's very high. And so this is Kaplan-Meier curves published from Santucci's shop when he was in Michigan. And it just, you can see that with, about a 50% chance of recurrence after a single urethrotomy will occur within the first year in his population. Now, I'll be honest, I think he's the most conservative of numbers that are out there. I think there are other publications that suggest that after an initial urethrotomy, you may get several years of benefit without needing any further prior intervention. I think one thing that Santucci falls in line with the remainder of the literature publications, though, is on subsequent urethrotomies, the failure rate and the expected survival is much higher. And certainly by the third intervention, you're barely going to get over a year in any of that population, and 50% are failing in less than 6 months. And so with this kind of information that has been published with a high degree of replication from different centers, the recommendation is a single intervention for urethrotomy is reasonable to do. After that has failed, it is completely reasonable to offer a open repair. Now, some of my personal feeling in regard to conservative management of strictures are as follows, and this is also evidence-based information, but dilation is as effective as incision. So whether you're doing a DVIU, whether you're using serial dilators over a wire, whether you're using a balloon to dilate the stricture, or whether you're using laser, any kind of laser, the energy source or the type of dilation really does not make any significant impact on what your long-term outcome is going to be. The long-term outcome is poor if you've had to do any of these procedures more than once. Successive urethrotomies is just a futile procedure, and it extends the stricture length with each incision, so it makes the definitive intervention much more difficult. If you have a stricture that's less or 2 centimeters or more, even if I'm initially meeting a patient that's never had a urethrotomy, if their stricture length is 2 centimeters or more, I don't even recommend doing a urethrotomy because it's just going to reoccur. It's just too much urethral segment to expect that to heal without having a future follow-on procedure. There is some evidence to suggest with that initial urethrotomy, if you inject steroids or mitomycin or other anti-proliferative agents, you may prolong your success rate or time before that urethrotomy fails. It's not really, those publications aren't really ready for prime time, so it's hard to say definitively whether that alone is going to be incorporated into the AUA guidelines. And it's not something that I do because, again, I'm just not a big believer in urethrotomy as a durable cure for stricture disease. So our general considerations, when we are moving on to doing a reconstructive type of procedure, is that we want tension-free anastomosis. The tissues have to be mobilized. This is just plastic principles in any kind of surgical repair. You want watertight closure. We use, obviously, a dissolvable or absorbable suture. I use delayed monofilament. I typically use 5/0 PDS with everything for the urethra. You want non-overlapping suture lines and multiple layers in closing, yada, yada, yada. I think that The extreme lithotomy position is the only way to truly access the perineum. And I've had great luck just using a very simple Lone Star retractor for the majority of my cases. There are fixed retractors called the Jordan Bookwalter retractor that definitely is an advantage for deep membranous type of injuries. We don't have one at our institution, so I've managed to get by with the Lone Star, but there certainly are cases where using a fixed retractor like that would be an advantage. So, you know, location and other topics as to what we do and where we go with each of these is going to be the source of the follow-on discussion. Yeah, and you know, this is just a summary of what I've said in the prior talk. Is just that, you know, for posterior membranous strictures, it's typically a traumatic injury. The suprapubic tube is in place. You want to do an antegrade and retrograde evaluation of the entire stricture to figure out just exactly how you're going to come about this. All right. Thanks. I apologize for the dryness of this material for the first phase. I promise we'll get much more interesting things going with the next series of discussions on the urethral reconstruction. And are there any questions at all? Great. Okay. Thanks, guys.
So, Joe, a couple of quick questions for
Sure.
some of us who don't do this at your level. So if we come across a urethral stricture, remember that patient we were going to do a prostatectomy and we saw a stricture. We dilated it and put a catheter in, and you were not too thrilled with it. In a situation like that, what would you like us to do? You know, I go in, I see a stricture now.
I think that you are intraoperative. Your plan is to do a prostatectomy and you run into a stricture. I think all bets are off and you got to do what you think is best to do at that time and in that situation. And you decided to dilate him and put a catheter in. I have no criticism of that at all. I think that's fine. I think the bigger issue is the patient himself, trying to get him in and evaluated by me so that we could time his planning for what kind of surgery he would need next was the bigger issue. When I did a follow-on cystoscopy of that guy, his urethra looked absolutely fine. So I think that he had some sort of very filmy stricture that was very proximal, and it was very appropriate to abort the prostatectomy at that time. But I think it's completely reasonable to do what you think is the best thing to do at that time. And you did cystoscopy, you saw the stricture, you decided to dilate and put a catheter in.
So from an outsider's view, Joe, this is clearly, you know, that St. Lucia's graph that shows that repeated, you know, DVIU has a very high failure rate, especially after the first attempt, which is conceptually different from several of us who trained in residence at, in the 90s and early 2000s, because that paper came out in 2010. Now, so in general, if we have a urethral stricture and we contemplate reconstruction or referring to a specialist, the best possible thing is for us to put an SPU tube and leave the specialist handle the urethra instead of us trying to do something on the urethra, unless it's a real soft, flimsy stricture that I can just stretch quickly without too much trauma.
Yeah, I second that thought process. I think that the patient who's in near retention or retention, who's had prior interventions for a stricture, and the stricture is the cause for the recurring retention, I would much rather have the urologist that urgently takes that patient to the operating room, rather than redilate them again and then send them to me with a catheter in their penis. I much rather prefer a patient that they just, on that episode, put a suprapubic tube in and send him to me for what's next. I have no problem with that. I'm happy to see that patient. I'll be very supportive of why their urologist didn't just dilate and put a catheter in their penis again. I think it was the right decision. And I think that that's really where the AUA wants us to move, and that's where the guidelines are pushing us to do is just stop the madness. If this guy is on his third episode of retention and he's in the ED and can't pee and he's been dilated in a catheter placed multiple times before, just put an SP tube in. Don't remanipulate the urethra.
Okay. Thank you, Joe. Any other questions for Dr. Costa? Thank you, Joe, as always.
Thanks, guys.
Thank you.